would now request Dr. Sonam again a consultant in orbit, oculoplastic aesthetics and reconstructive services from Shankar Netralaya, Chennai. Yes. From Chennai, and she is going to be telling us about ophthalmic evaluation in DCR. Let's hear this very energetic woman telling us some more. On to you.
Yes, thank you so much, ma'am, for that kind introduction. And at the outset, I'd really like to thank the entire organizing committee for giving me this opportunity. So I've been asked to talk about evaluation of epiphora, and I'll be obviously covering ophthalmic investigations of DCR as well. So, well, I just like to put the title that there's nothing to cry about epiphora. We all know about the lacrimal drainage system and the lacrimal apparatus, which actually consists of the punctum, the canaliculitis, the lacrimal sac, and the nasolacrimal duct. What is also important to understand that the ocular surface and the eyelids also play a very important role here. So when a patient comes to us with watering, we need to understand that there are two components in watering. One is lacrimation, that is hypersecretion, secondary to an underlying pathology like any underlying infection, a foreign body, and so on. And then there is epiphora. That is because of any altered or compromised lacrimal drainage system because of an NLD obstruction, canalicular stenosis, or punctal stenosis. So when we talk about evaluation, it goes back to our basics. That is any evaluation that we've learned way back in our MBBS. History taking is extremely important, followed by your inspectory findings, your palpatory findings, slit lamp evaluation, that's add-on findings that we can find, and imaging also. So history taking is very important. We start with obviously looking at the age of the patient. You have to ask for the duration, type of watering, onset, and the type of discharge that is associated itself will give you an idea whether there is mucopurulent discharge, there's mucoid discharge, or it's just plain watering. Also, you need to look for any associated complaints, whether there's any associated pain or any swelling around the medial canthal area. Any history of trauma also has to be ruled out. Any history of previous surgery or infection also must be asked for. We also must keep in mind systemic diseases, as we know that dry eye is associated with a lot of systemic conditions. Punctal stenosis can occur as a cause of many drugs that are being given. And we should not forget asking about any topical medications like AGMs, that is anti-glaucoma medications also, because we know that AGMs are associated with punctal stenosis and a lot of other ocular surface conditions as well. So when the patient comes to us, the first thing that is glaring is the tearfilm meniscus height. That is the first thing that will give us actually an idea about what's happening, whether actually the patient has any watering, is any blockage, or what is the thing. So tearfilm meniscus height is one of the most important evaluations that you can do without even touching the patient. Next, you have to look at the periocular area as well. You have to look for the lashes, how the lashes are. Any chronic epiphora, watering, or an NLD obstruction might be associated with matting of lashes as well because of any mucoid or mucopurulent discharge, which is causing stickiness there. Next, we also need to look for the periocular skin because of constant rubbing of the tears. Many patients that you see might come to you with a little bit of periocular hyperpigmentation, periocular scaly skins, or any contact dermatitis because of epiphora as well. So these are the three things that we must also look into. Next, of course, we have to look at the lids. We have to rule out any lid malpositions such as ectropion, entropion. Also look for the blink rate and evaluate the entire face. Yes, nowadays we're seeing all patients with masks on, but it would be very nice if you could just remove the mask and also assess the facial asymmetry there. We have to assess the blink rate. We have to assess the orbicularis tone and look for any lagophthalmos as well. So when we talk about the lids, we have to look for any lid laxity, which includes doing all the standard tests that we do for lid laxity, such as your snapback test, your distraction test, as well as your you have to look for any floppy eyelids as well. So all these tests must be done as a patient department when we're actually looking at the patient as well. Medial canthal and lateral canthal laxity also must be assessed for. Next, when we are inspecting, we must look at the medial canthal area as well. Why? Because yes, that is where the sac is. It lies in the lacrimal sac fossa. Any inflammation, any acute or chronic dacryocystitis, any lacrimal sac fistulas can often be missed. So that is one area that we must assess properly. Now, one point to notice here is, why is this line here? We all know that any lacrimal sac inflammation that is related to NLD obstruction generally does not cross about 2 millimeters above the medial canthal tendon. That line technically indicates your medial canthal tendon. In case you see a mass or a fullness in the medial canthal area, which is actually extending beyond 2 millimeters, then we must be a little worried and suspicious. Ask for imaging because it could be a lacrimal sac tumor as seen in this case as well. Coming on to the next thing, ocular surface. Yes, ocular surface is very important. We must not neglect that. Ocular surface, why? Because we have a lot of patients with chemical injuries or any cicatricial conditions like OCT who might come to us with epiphora and watering. It is very important to look at the phonesis, to look for any symblepharon scarring. Also, it would be wise to avert the lid and look for any scarring in that area. Look for any LMK, that is any keratinization also, because that itself can cause your hyperlacrimation. And we must identify we must identify the underlying pathology and rule it out. In slit lamp examination, it will be very important to assess the puncta size, shape, and position. And many a times it is very important to assess the puncta, especially in CNLD patients, because when you take up the patient and you see the patient actually had punctal agenesis, how are we going to explain to the parents that we cannot do a probing? So this is one thing that is very important that we must look for. Of course, Centurion Syndrome, that is anterior insertion of the medial canthal tendon, also is one of the causes of epiphora. Canaliculitis is a masquerade of nasolacrimal duct obstruction, and that is something that must be looked for. The most important test is Roplers, that is regurgitation on pressure over the lacrimal sac area. And it has been proven that self-Roplers can be used as a screening tool for the patients. When we're doing syringing, these are the tools that we must keep ready in our OPD. And syringing probing is very, very important. In children where we cannot do syringing, we can do a fluorescent dye disappearance test. As you can see in this trial, you can see FTT at 3 minutes and 5 minutes is much higher as compared to the other eye, suggestive of an obstructive etiology. We generally tend to use a 26 gauge needle for syringing, and you can start probing with 00 probe. If you get a hard stop, that is suggestive of a nasolacrimal duct obstruction. But if you get a soft stop at less than 6 millimeters, proximal canalicular block, more than 6 millimeters, suggestive of a distal canalicular block. So these factors are important in also planning your surgery. This is just a simple 3-probe test that I'd like to highlight to also talk about lacrimal fistulas, congenital fistulas, because that will actually tell you where exactly the fistula is originating from. You can trace the tract and then excise it or plan the management accordingly. To conclude, imaging plays a very, very important role in assessing nasolacrimal duct obstructions also. This is a case where you can see it's actually a DACRYOLOGY seal or a DACRYOLOGY seal. We just had to go ahead and do an ultrasound and we figured out what the fluid was. The child underwent probing syringing. Of course, he had a large intranasal cyst which was seen in nasal endoscopic evaluation, which my colleague Dr. Pratibha will be covering. DACRA cystogram, CT, DCG, and MR DCG is also a very important investigations of choice, especially in cases of traumatic NLDOs or indoors, that is iatrogenic nasolacrimal duct obstructions. It actually can tell you where the sac is avulsed or what exactly is causing trauma at the level of the sac and NLD, and can help you plan your surgery much better. It's a very simple procedure. You just put a dye. Either you can put as a drop or you can inject the dye, and then you take serial sections, and you can see here in the image how beautifully you can see that here there is a 2-point plate which is actually dissecting and causing avulsion of the sac and the NLDO. And you must do imaging in special concentration, like this patient who actually has an arynia, and you can see that she has only one nose, but right side she has a sac and she had Roplers positive. She had a nasolacrimal duct obstruction. Technically there was no nasolacrimal duct here. So in order to plan your further surgical management, this imaging will help you plan better. And to conclude, yes, hemolacria is another condition where you might have NLD associated with hemolacria, like in case of rhinosporidiosis, and you must do a thorough evaluation for the same. And also beware of malingers like this, who actually came to our OPD saying that she had bloody tears, but you can see what she's actually done. She just painted around herself. To conclude, we must identify the cause. It is very important to assess the level of the block, identify the cause, do a detailed evaluation, and when in doubt, always image. Thank you so much.
Wonderful talk. Wonderful, crisp talk, and covered it all beautifully. And one basic question, Dr. Lakshmi Mahesh, if a patient has a sac pathology and also a lid abnormality, would you do them as a staged procedure or would you do them both together? Yeah.
You mean to say a lid abnormality and a sac procedure?
Yeah.
Definitely the sac first.
Okay.
Always the sac first. But if the lid is a minor problem and the sac infection is well controlled, sometimes you can think of repairing it in the same sitting. But if it is a deep wound or a deep defect or something like that, first it's better to repair the sac. But there are a lot of injury cases when there is a lacerating wound of the eyelid that has to have a repair. And in that, if the NLD is exposed, if the sac area is exposed, then we could do a DCR or finish the repair of the lid first and subsequently do the DCR. We can't leave an open wound of the lid though. This is in acute injuries. But when you get a chronic condition and you have to work on the lid for further reconstruction, it's better to fix the sac first.
Dr. Arvind?
Thank you, Dr. Sonam, for bringing all your energy into the talk. My question is to Dr. Shreya Shah. Even today, we get referrals of patients who sometimes have canaliculitis, but who present just like a chronic dacrocystitis. What are your tips for differentiating both these conditions, madam? Dr. Shreya, you're muted. Can you please unmute yourself?
Sorry. So when you see the patient, when you suspect the patient for canaliculitis, usually they come with pain, first thing. Usually when there is acute and chronic dacryocystitis, the history will tell you that it was repeatedly NLD block and now they have come for acute and chronic. But when there is a canaliculitis, the first thing, the moment you dilate and you try to put the probe, the whole things come out immediately. It's like popping up the pus from the abscess. So that one thing will definitely say. Second is you will be able to do syringing and there may not be, they may be patent. So that is the sign that that is simply a canaliculitis. And when you see canaliculitis, you have to look for all other causes which are responsible for canaliculitis. The most important thing what nowadays is, even sometime it happens that simple acute conjunctivitis, it's not treated and it has created. Second is dacryolyth. So sometimes just small stone-like structure which stucks into the canaliculus and it repeatedly causes abscess-like structure in the canaliculus and then it becomes acute and chronic canaliculitis.
Thank you, madam. I think that is a very relevant topic, especially for people who are evaluating them. And unless we differentiate, even a great and well-done surgery for the wrong indication will not actually benefit the patient. Is Dr. Vikas Menon here? I don't see your, I just want to ask you. Or Dr. Saptagirish, can I pass on the question to you? Can you please turn on your camera?
Sure. I'm audible, right? You can show.
Yeah, you're audible. My question is, how many CT DCGs do you advise? Do you have a thumb rule to decide who to image and who to go ahead with surgery without a DCG?
Actually, I don't do much of CT DCGs unless it's very much indicated. Like when I'm thinking very much of a tumor, actually, which is pressing on the lacrimal system, whether it's involving or not, I would not do a DCG. So, yeah, looking back for the past 10 years, I've just maybe have ordered only about 2. Maybe that's what I got over here. And those 2 also were just actually passive compression, and we just got away with the removal of the lesion. So I don't routinely do a lot of CT DCGs. Maybe it depends on the practice, I guess. But you have to have the indication for doing it. You have to have a lesion and you have to go by your clinical findings, and then you decide whether you actually need to do it or not. And in spite of, sometimes you may find a lax sac and you may think you'll do a DCG, but that's not going to change your management plan. So there's no point doing it. Well, that's my practice. That's the way it is.
So the speaker would like to add some points, so I'll give her an opportunity. Dr. Sonam?
Yeah, thank you so much. So we do CT-DCGs, especially in cases of traumatic nasolacrimal duct obstruction. So where we know that there has been some intervention that has been done before, like in case of endo, because that actually helps us plan our management better. Whether we need to remove the screws and the plates, whether we need to trim the titanium implant medial flange, which is actually bifurcating the sac or not. So those cases, it actually helps us plan better. Also, like I showed the last case of A-rhinia, when we do a CT-DCG and we do an imaging in that case, it will actually help us plan where exactly you want to do the DCR, because generally in case of A-rhinia, they say you can actually do it through the septum, like you can do it like a transseptal DCR, or you can also do a DCT depending upon the eye condition. So it would help us in planning better is what I would just add on to that. Thank you.
Arvind, a couple of points, I think.
Yes, Dr. Please.
Right. Now, I think right from the time when we initially started CT-DCG, maybe about 15 years or 20 years back, the indications for CT-DCG have actually widened in my practice. My threshold for doing a CT-DCG is fairly low. I mean, I don't do it for all cases, of course, exposing a patient to radiation and things. But all cases of trauma, like Sonam mentioned, all cases of trauma, because it will help you to see the extent of scarring, callus formation, and any other distortion which you should be prepared for, because your surgery is likely to be more challenging than a routine pando case. The second is we have all the patients with failed surgery that are not clearly able to identify a cause in terms of whether the canalicular system, because the canalicular system is the bugbear. If you have an ostial closure, you can very easily open up the ostium from the lower end, like endoscopic, or from an open approach. But if there's a combined canalicular block as well, so this also helps us to delineate. I mean, a well-done CT-DCG is a beautiful test which will help you to see the canalicular integrity, the relationships, the scars and things like that. Also, one unusual kind of a situation which we don't see that uncommonly is a failed DCT. Now, what is a failed DCT? A well-done DCT should be the end of the patient's misery, with the sac completely taken off and the canaliculi, ligated, scarred, cauterized, and the patient should live happily ever after. But there's a large number of patients who are operated at smaller centers by budding surgeons. It's pushed to the end of the list in many government and other hospitals, where the youngest postgraduates gets a hand at doing surgery. And these are not actual DCTs performed. Either a part of the sac has come off, or a part of the lacrimal sac fascia has come off, or everything has been abandoned because of bleeding. So there are many of these failed DCTs where they still continue to suffer with regurgitation and discharge and all that. And when you syringe, obviously it's blocked and some discharge comes out. So these to delineate, because if there is significant amount of sac tissue left, then I would like to go ahead and do a DCR after a DCT. I mean, it sounds a little funny that you're doing a DCR after DCT, but there are many, many cases where I have done that. And it's obviously for the patients better, rather than so-called going and completing a DCT. If only a very small portion of the sac has been removed or not even removed at all, then you would like to do a DCR for the patient and give him or her a better quality of life. So that is another indication where I found it very useful. Your radiologist can very clearly delineate and say that there's significant amount of sac tissue left for you to possibly go ahead and do a DCR. Or no, it seems to have been a well-done DCT, there's no sac at all. So in those cases, I would go ahead and remove whatever remnants are left and make the patient free of symptoms. I think these are the common indications. And anything extramural, anything which looks atypical. I mean, we see NLD blocks day in and day out. So anything which doesn't fit in, for example, the mass seems to be extending above the MPL, or anything else which is atypical, you will go ahead and do a CT-DCG, which will beautifully delineate your entire passages for you.
Thank you, Dr. Mohan. I think that kind of encompasses all the indications for a CT-DCG. I think the message is there is an option for imaging, not for all patients, but for indicated ones, definitely it's something we can consider before planning this.